options, of course, you can do nothing. Where are the dangers of nothing? There are dangers that the patient keeps getting sicker and sicker, and that's fine. Sometimes people think if I get 5, 6 sinus surgeries, I'm okay with it because I'm used to it. But then again, it's causing damage in your system. Every surgery we do, you're taking normal tissues from that. And then you have also the damage of getting some damage to the lungs. Bronchiectasis is always a warning sign for us. This is when your lung tissue starts getting destroyed, and if it's destroyed, it can't fight very well and it can't breathe well. Now, the second option that I have used quite often in my office because there is no ability to do immunoglobulins is I have put my patients on prophylactic antibiotics. Prophylactic means preventive. So why do you do preventive? Most of the time you do low-grade antibiotics, so these are the easy ones, to prevent from having infections, but then again, it's not treating infections. So somehow some people do well. You run into the risks of if you take antibiotics all the time that these infections start becoming very resistant. So you're gonna have to run into the situation where, you know, maybe I should alternate and take antibiotics. That way I can prevent resistances. But again, there is always the risk that sometimes you get an infection and there's no antibiotic that can help because of this use. So our last topic, which I'm gonna elaborate a little bit more on, the immunoglobulin replacement. So what is immunoglobulin replacement therapy? Is basically is to treat, infuse the body with antibodies or immunoglobulins that the body is not making. So we go back to my analogy of if you have a military lab and you have a particular area where it's lacking, what you do, you hire mercenaries. So you get some trained soldiers and you infuse them. In other words, you get them from people actually that have gathered. These are donors that have given thousands of people give blood, and then you will find them that they are very carefully screened. And when we say very carefully screened, these centers now they have gone into the habit, or they have this whole system of they have a very well-known pool of people they come and donate. It's not like anybody walking on the street and give us blood or their blood. So these people are known, they know their medical history, they don't take drugs, they're very healthy, and they don't do it for money. So that makes a lot of difference because sometimes people, when they want money with your blood, you can be, taking drugs or anything, so the blood is not as pure. But nevertheless, no matter how the blood is impure, it goes through a very strict condition to ensure safety. And when we say strict conditions, studies have been also done on HIV positive blood, and they run it through the system how to make it safe. And at the end of that series, there was no HIV. So we know it is safe. All these strict safety conditions are really safe. So how do you take immunoglobulins? You can infuse them. Now it is very common. You do it under the skin, subcutaneous. That means in the subcutaneous tissue. And what you do is basically do it something you can do yourself with the use of a small needle and a infusion. And there's also the most common that's still widely used is to do it via the venous. And you have to have an access to a medical facility first, and you have to have a vein, access to a vein, and then you don't do it as frequent, you do it every 3 to 4 weeks. And literally all what it's doing, it is replacing what the body is not actively being able to make for fighting infections. You're giving it passively. And that's because the donors are healthy people that immunoglobulin is trained to fight any kind of infection. So when you infuse it, the body senses that when there is an infection, they come and fight until they just wean off, and you have to replace it again because they don't last more than 21 days, maybe at the max 28 days. That's why you do it monthly. And for the subcutaneous, it's a different way because it lasts, and that's what we're saying here. It's consistent serum level, and that's why it's becoming more popular. When you do it in the fat tissue, the absorption is slower, so you don't have a peak. I have an infusion and it goes quickly, and then I'm tired before the next infusion. This goes steady, it takes a steady level, and you have a maintenance of your IgG a little bit more stable throughout a week. You have to repeat it another week and go over and over again to keep that constant. So the choices that you make is either are good. The only difference is when you do IVIG, you have down their pills or any of these things needed. So you will be a candidate for a subcutaneous treatment if you are you can self-infuse. Some people are very uncomfortable doing this and they refuse to do that. But you need to have training. So we do that in the office before the patient really shows a comfort. And you can do certain activities while you're infusing it at home. And you can schedule them whatever time works for you. On a Sunday afternoon or on a Saturday morning, whatever works for the schedule of the person. As we said, I mean, I'm talking more subcute because it's more new, but it's basically it gives people more freedom and flexibility. Particularly because people have a hard time, and little kids sometimes we have that issue, or some people have problems having veins every time you come in, you're struggling to find a vein to infuse. And then of course they have some side effects from the IV route, and they are not happy. Also choice if you're not happy with the IV. So basically, when we get diagnosed with immune deficiency, I mean, we need to. It's not only about giving you infusion and sending you home. This is not like, okay, this is a prescription, good luck with that, call me if you have problems. This is a whole multi-facet, and a lot of people are involved in the treatment of immune deficiency. First of all, we have to be aware that we have a chronic disease here. People are living with this. It's not a little infection that goes away. We have to understand what is the treatment, and the patient does need to understand that treatments can be forever or can be for a short period of time. Of course, there should be a lot of help. We would like our patients to be involved in the decision making, and of course, communication, and the patient has the choice. Always keep that in mind. You have the choice. So the chronic care approach, these are basically what we're talking about, is that, you know, there is no acute therapy. It's not a pill. Give me a pill. I have actually a patient, and that was so sweet. It's like, don't you have a pill? And I get done with it. I said, I wish we had a pill, then we don't have to worry about all that stuff. But you know, it's not a cure. It's not a quick fix, and it needs a lot of patience. Of course, it does have a lot of impact. I mean, physically, you are always tired. There's fatigue. So when we bring the patient to the treatment, they notice the first thing the patient notices before they start having infections is I have energy. And this really does have an explanation why you have energy. Because you know when your immune system is lazy, so you're using more other places to fight a very simple infection. So you're using a lot of energy to fight something as simple as common cold. That's why you're drained, because your body is exhausted. It's doing 10 times the job to fight an infection that is as common as 2-3 days, and it's gone for regular functioning immune system. Socially, it does have an impact. People are always sick, the families, first of all, they can't go out, teachers, they worry, they have kindergarten students. I mean, this is like a big deal, they're all snotty noses. And sometimes I have to tell them, you're gonna have to change this job. You can't be around infections all the time. So that changes your lifestyle, that changes your social life. Sometimes you can't see your little kids or your little children who are sick. It's like, I can't visit this weekend, they're sick or something. So that's affecting, of course, the economic and like anything in the medical field. The high need for support, yes, we do really put an emphasis on this. Our patients need to have the support. And then we are going to talk about some transition there, like when you are actually being treated, what basically you need to have is, I need to get to learn that I have this problem, and I have to learn that I need this treatment, and it's going to change my life. But we really push for the support, and it works really well once the patients find some benefit from the treatment. So this is the comprehensive, a little chart to show